Welcome everyone to the second annual Erich Lang Lectureship in Urology. We are absolutely thrilled to host Dr. Menon, who will give us a talk entitled Prostate Cancer, Lessons from Bernard Fisher. So I wanted to review the career of the doctor who has made this outstanding professorship possible. Is Dr. Erich Lang, who many of us know very well. And Dr. Lang is really one of the true pioneers of interventional radiology. Along with Dr. Sabiston, he actually first described coronary arteriography. That's a big deal. As many of you know, the first cardiac catheterization was actually done in the 1920s by a German urologist named Werner Forssmann. He won the Nobel Prize. He actually did that cardiac catheterization on himself. So cardiac catheterization is one thing, but coronary artery catheterization is yet a whole nother thing. So one day in the halls of Johns Hopkins Hospital, Dr. Sabiston, who was one of the scions of Alfred Blalock, came up to this young fellow in radiology and floated this idea, and Dr. Lang was game, and of course in those days you could get away with a lot more experimentally in living people than you can more recently. And while Dr. Soanes is given credit for the technique that we use today of coronary angiography, it was actually Dr. Lang, backed up by Dr. Sabiston, who did that procedure. And he has told me this story, but he doesn't advertise it much, and he doesn't really want to take credit for it. But I think it's just an example of the type of individual that he is. And he is a key opinion leader who combines tremendous skill, spirit of innovation, with unbelievable kindness and humanism. So through his kindness and generosity, he's donated a grant to fund this annual eponymous lectureship here in the Department of Urology at SUNY Downstate. A little bit of background: he finished at the top of his class in high school in Vienna, 1947. He got a master's in Columbia as a Fulbright Fellow, and he received his MD degree at the University of Vienna, where people like Sigmund Freud got their medical degree. This is 1953. Postgraduate radiology research fellowship, came to the United States and did an internal medicine residency at the University of Iowa, really one of America's great institutions, and then became a resident in radiology in the late 1950s at Hopkins. So he became an instructor. He then went to Methodist Hospital, which really was not as well known at that time as it is today, as part of Indiana University, and became the acting director in '61. Then went to LSU Shreveport and became the professor and chair, was recruited heavily there. And that was his first foray into the state of Louisiana, which remains his home. He lives in New Orleans. So he came to LSU New Orleans in '76 and was professor ultimately until 2000. He also worked at Tulane, and he interestingly traveled quite a bit. We worked at SUNY Downstate through my predecessor, Dr. Richard Macchia, for many years, and we benefited greatly from his innovation in interventional radiology here. Professor in radiology at Hopkins for many years. 443 publications in refereed journals, 68 book chapters, 567 presentations at national and international meetings, and 13 editorships or associate editorships of refereed journals. He also did military service for the United States, attained the rank of major in the 337th General Hospital at Fort Harrison in Indianapolis. So now to our guest, Dr. Menon, who I know is really embarrassed about all this, but I'm sorry, I'm going to embarrass you a little bit, Manny. He is the Rajendra and Padma Vattikuti Chair in Oncology at the Vattikuti Urology Institute at Henry Ford Health System in Detroit. His education started in India at the Jawaharlal Institute of Postgraduate Medical Education and Research, otherwise known by the acronym of JIMPER, in Pondicherry, India, and did his residency in urology at the Brady Department at Hopkins. He worked with Dr. Walsh at Hopkins and developed a technique to measure androgen receptors in the prostate, the first to do so, and later moved to Wash U in St. Louis, where he became the youngest tenured clinical faculty member soon thereafter. In '83, he was recruited to the faculty at the University of Massachusetts in Worcester, where he started the Division of Urology and Transplantation, and at age only 34 became the youngest chair of urology in the U.S. That department thrived under Dr. Menon's leadership, and after which, in 1997, he was recruited to Henry Ford to invigorate its prostate cancer and urology program. 2001, Dr. Menon headed a team at Henry Ford Hospital doing the fateful Vanguard robotic radical prostatectomy, which has completely revolutionized urology, I think very much in the same manner that Dr. Walsh himself revolutionized urology by discovering the anatomic locus of the nervi erigentes and giving us all of the important steps to do radical retropubic prostatectomy. Dr. Menon's technique resulted in complete transformation of this approach from a traditional open to the robotic approach. And his trainees worldwide, and I think he considers this his greatest accomplishment, are the trainees who continue to improve upon his pioneering work in robotics. He himself has published more than 300 papers, mainly in robotic surgery, but many other areas in urology, which have appeared in all of the highest impact journals, including New England Journal of Medicine. He's a past member of the National Kidney and Urologic Diseases Advisory Board and is a trustee of the American Board of Urology. He's had many honors, of which some are listed in this roster: Gold Cystoscope, Top Doc, International Who's Who. But there was a compendium of the greatest, most important immigrants that came to North America from 1600 to 2000. So that would be one per year. Now, how many immigrants have we had come to North America? You know, how many? 100 million? And one per year. And the most recent one in the year 2000 was actually Dr. Menon. I think that's one of the greatest honors that anyone could possibly have. So we thank Dr. Lang, who gives his regards. He's been ailing. He's in his late 80s, but is still living in New Orleans. And we thank Dr. Menon for coming, and I can't wait to hear the lecture that's coming up shortly.
Thank you, Dr. Weiss. My daughter works in Brooklyn, and I wish my son and my daughter had been here. My son would have been proud of me, proud of this introduction. My daughter would actually have believed it. I wanted to talk to you about a new thought on the treatment of prostate cancer. This is a precision prostatectomy. And I titled it Lessons Learned from Bernard Fisher. Dr. Fisher is 100 years old this year and was a seminal surgeon who transformed the field of breast cancer. It was at Pitt, just like Dr. Weiss was, so I thought that there would be a connection there. Some of the parallels between breast and prostate, and I don't want you to take this to ridiculous extremes, but 5 or 6 years ago, there were 230,000 women diagnosed with breast cancer, and about the same with prostate cancer. 1 in 8 women would get breast cancer, 1 in 7 would have prostate cancer. Was the most common type of cancer in men, was the most common type of cancer in women. 14% of all cancer cases, and it's a diagnosis of the elderly, people in their 60s. This is from the NCI website. You may have heard that the mortality rate from prostate cancer is only 1.8% or less than 2%. In other words, there's no point in even trying to treat it because most people will survive the cancer. But that truly is not the case. The mortality in the United States is 18%. So of all the people with prostate cancer, 18% of them are going to die. And in Great Britain, where the cancer is treated even more lackadaisically than it is here, the mortality rate is around 24%. And for the purposes of this talk, I wanted to put this mortality in perspective. 40,000 women died of breast cancer, and that death rate has not changed from 2000 to 2018. About 30,000 men die of prostate cancer, and the death rates have remained roughly the same. Colon cancer in men, the same number of deaths as prostate cancer. Yet, colonoscopy is required, recommended for screening, and a PSA is talked to them. I can't understand why there is such a disparity in screening recommendations. And just to keep things in perspective, these are the number of homicides in the United States. So you can see we've not done much to lower the death rate from homicides. Neither have we done much for any of the cancers that we're treating. Yet, the treatment of breast and prostate cancer are completely different. Very few women with breast cancer are treated with active surveillance or radiation therapy. About a third of them were treated with radical surgery, mainly by patient preference. These numbers are from 5 years ago. Numbers are hard to get, so I haven't been able to get updates about this, but I understand that most women with breast cancer get organ-preserving surgery. For prostate cancer, about a third of men are treated with active surveillance, or a quarter of them. A quarter of men are treated with radiation therapy. Most men are treated with radical surgery. No one is treated with organ-preserving surgery. Why is it that we have two diseases that act on elderly individuals, and why is it that the treatments are so vastly different? Now, surgery happens to be a very good way of treating prostate cancer. These are our results of the first 5,000 patients that we treated from 2000 to 2014 with robotic surgery. I don't mean to say that our results are any better or any worse than you could get at Memorial or Hopkins or Downstate, but you could see that out of these 5,000 patients, we had 30 patients who went on to die of prostate cancer at a 15-year follow-up. So surgery is very, very curative. Why then don't we do PSA testing, diagnose people, and treat them sooner? And I think it's because of the side effects of surgery. The two major side effects are incontinence and impotence, and I would just like to focus on the ED aspect of it. This is a study that appeared in JAMA from Dan Barokas, and it is the Medicare SEER data, and it looked at functional outcomes in men who underwent active surveillance, external beam radiation, or radical prostatectomy. And it simply looked at erection sufficient for intercourse, and you can see that men who had active surveillance, there was no change in erectile function. The changes that you could see are those of aging, and over a 3-year period, you can see that there is no change whatsoever in erectile function if you had active surveillance. If you had radiation, that's the red line, or surgery, there was an immediate change in erectile function. With surgery, functions got better over a period of time, but at the end of 3 years, still 2/3 of men were having erectile dysfunction, whether they were treated with surgery or radiation. The shaded area shows the overlap of the confidence intervals, and what it shows is that after 2 years, there is really no difference in whether you had radiation or surgery. 2/3 of men had a change in erectile function. And maybe that is just because people didn't know how to do surgery or radiation. The average surgical volume was 4 cases a year in this group. And maybe expert surgeons won't have such bad results. So I want to kind of show this slide, and I'd like to spend a minute or so having you talk about this. Now, you trained with John Mulhall, and this is John's data. And I think it's online, or it might have just come out last week in European Urology. And the title was, "Are We Improving Erectile Function Recovery After Radical Prostatectomy? Analysis of Patients Treated Over the Last Decade." And the 2 surgeons whose patients were looked here were Peter Scardino and James Eastham. And you rotate out a memorial, and you know the quality of surgery that these surgeons have. So, what does this slide show you? What's the take-home message from this slide? Anything? I mean. So we're not doing any better. We're doing just as badly as in 2015 as we did in 2008. And these are 1-year outcomes, and these are 2-year outcomes. But what are these outcomes? What's the x-axis, the y-axis here? It's 20% and 30%. So essentially what these surgeons saw is that the potency rate following nerve-sparing radical prostatectomy in Scardino's and Eastham's hands was 27% at 2 years. Well, maybe that is good. Maybe it's not that good. Understand that John Mulhall has a very active penile rehab program, and 30% of these men were on injections. Yeah. So the bulk of these patients were robotic, and essentially what this paper showed is that the addition of robotics and other techniques made no difference in that. So 2/3 of the patients were robotic, and 1/3 of them were open. So, and there are other slides that show that the age of the patients that are being operated on in 2015 was higher than the patients in 2008. So age-adjusted, but these are age-adjusted ratios. If you actually looked at the potency rate without age adjustment, the rates came down. So they found no difference, robotics versus laparoscopy versus open surgery. So that is one of the things they looked at, which surprised me, but those are the numbers. I mean, these were all patients who were examined very vigorously. Now, it didn't come entirely as a surprise to us, and I wanted to know exactly what you did. Maybe there's a difference in surgery done in Detroit versus New York. And what we did here is a cumulative incidence analysis, the same 5,000 patients that we saw, but I eliminated people who came in with ED, so the numbers now are about 3,000 as opposed to 5,000, since 2,000 men had pre-existing ED. All of the memorial patients were people who did not have ED. So this is a fair comparison, and what we saw was that at 2 years, our potency rates were no different from Eastham's and Scardino's. What we saw is that At 3 years, 4 years, and 5 years, the potency rates got better, so that people who underwent a bilateral veil, which is the red curve, at 9 years, about 70% of men had potency. We also found there was no difference in our erectile function rate, exactly what John Mulhall saw. So our impotence rate was exactly the same as it was in 2001, as it was in 2015, when you adjusted for all the risk factors that are there. So I'm going to go to the next slide and say, there are two ways in which you can deal with the slides that I showed. One is, you could say that I'm missing something and that my analysis is wrong, or you could ask yourself the question, if this is true, what does it imply? And I don't know whether any one of you knows who Benjamin Franklin is, but I don't know whether any one of you, Jeff, you do. This is Don Coffey, who was the head of research at Hopkins for many, many years, and a true visionary, a true genius. And anytime you went to him with the problem, he would not answer the problem with you, but he would tell you, if this is true, what would it imply? So I'm going to ask you, if potency rates are only 17% after nerve-sparing radical prostatectomy, what does it imply? I'm going to give you some time to think about that, and I'm going to do a card trick, because the next things are going to be a card trick. Up to now, this is all data. From now on, this is just hypothesis. So I want someone to pick a card. One of you, I want to volunteer. Ace of spades, okay?
Pick any card, or?
Yeah, pick any card, shuffle it, pick it, and show it around. No, show it to everyone.
Did everyone see?
Yeah. Okay, now,
Well, you're next door neighbors.
just, I did this at Hopkins, so I should be able to get away with doing it. Just show it to someone. Yeah, yeah, and then you need to show it to me, so that I'm also there. Yeah, so show it to. Yeah, or you don't have to show it to me. You just need to tell me what card it is. What card did you pick?
Why do I have to tell you?
That's the trick. If this is true, what does it? Yeah. So yeah.
Spades.
Two of spades. Okay. So, are you sure? Does everybody think it's a two of spades? Two of spades? Okay. So now this is a iPhone, Henry Ford associated iPhone. I have an app on it called Rising Car. And there's a deck that is loaded on this, and it's the Ace of Spades. So my Henry Ford phone knows the trick, because I'm told this is the two of spades. Now, he didn't show me the card, so I better take his word for it. So, would you take his phone and just shake it? What do you see there? You see the two of spades. There are two of spades. So, did you do this? Oh, interesting. Okay. So now that just. So the rest of this thing is going to be like that. It's going to be magic. So tell me, if everything I told you was true, what does it imply? And if you don't have an answer, that's fine. But just keep thinking about what it might imply. To me, it implied that we didn't know where the nerves were. And this is something that I've thought about for many, many years. And we talked about Eric Lang doing the first coronary angiogram. I had actually thought it was Mason-Sones until Dr. Weiss told me that. You know, Mason-Sones was a Henry Ford Hospital resident. This is where I work. And fable has it that he did the first coronary angiogram. We thought nerve-sparing radical prostatectomy was described by Dr. Patrick Walsh. But this is a paper in German from 1840 or so, and it shows cavernosal nerves which enter into the cavernosal body do not follow the course of the vessels into the phallus, but have a much shorter course. So it's not truly a neurovascular bundle, but it's a plexus of nerves that go into the cavernous tissue. It's just an anatomic dissection. This is Patrick Walsh, and I was his chief resident when he first described the neurovascular bundle, and he said that the nerves that maintain erection, the erectogenic nerves, the nervi erigentes, run at 5 and 7 o'clock position. If this were the case, these nerves are about 4 millimeters away from the prostate, and we should be able to preserve it 100% of the time. In fact, in a series of studies, I would do a Doppler ultrasound of the neurovascular bundle before and immediately after surgery, and I took the neurovascular bundle in no one. Every single one of them would have a pulse and pulsatile flow through the vascular part of the neurovascular bundle. And I would submit to you that if this is really where the neurovascular bundle is, it would be impossible for you to damage the nerves but preserve the blood vessels, because the vessels are wrapped around the nerves. Does anyone know who this is? Yes, so this is the median, and if you just walk around the corner, you'll see his photograph. Arguably, he is one of the, inarguably, he's one of the fathers of the MRI, but was he the one who did the seminal work is controversial. He did not share in the Nobel Prize, and he took full page ads in the New York Times complaining about the injustice of this. And if you go into this, you get into the same argument that yours, who described the neurovascular bundle, and you get into difficulties. But the reason I said that is, what Dr. Damadian did was talk about MRI, and this is a technique called MR tractography of the prostate. This is a slide from Cedars Sinai, and this is a slide from Mount Sinai, so both of them have a Sinai connection. And essentially, what they're doing with this MRI is not using the MRI to diagnose the cancer, but it's doing the MR to see what the nerve supply to the prostate or surrounding the prostate is. And I would submit to you that these nerves are so complex that it would be impossible to do a true nerve-sparing operation. Now, we can stop and argue about this, and whatever you say, I would agree. It's not clear that these are truly nerves, because these are images that are created from computers. These are techniques that are used to looking at brain tumors. In the brain, all you have are nerves. Around the prostate, you have muscle and connective tissue and all of that, so they may not be nerves. So this might be a false statement. Yes?
If this is true, wouldn't that imply that a TURP should result in erectile dysfunction?
No. So that's, it might. I looked at it the other way. I looked at it backwards and saying, why is a TURP not have erectile function? Why do people who have a simple prostatectomy not have erectile function? And that's because in a TURP, you're going through the urethra, which is on the inside, and these are nerves that are on the periphery. This is the capsule of the prostate. So these are nerves that are intimately attached to the capsule. So if you did a radical cystectomy, a cystoprostatectomy, you can do that operation just enucleating the prostate and leaving the prostatic capsule. Even the worst surgeon, you don't have to be an Eastham or a Scardino, you'll have about 100% potency. So what I thought is, if this is true, what it means is there are around 3,000 to 4,000 nerves that maintain erection. When you do a radical prostatectomy, you damage a certain number of those nerves. You might damage 1,000, you might damage 2,000. Some men only need 1,000 nerves, and these are the men who are potent. Other men would need all 3,000, and they become impotent. So, again, I'm going back and saying, this is all theory, but this is the way the impression that I had. Now, this is another study that came out several years ago. I'll say there was a fellow in France, I forget which university. Then he came and worked with Ashutosh Tiwari at Mount Sinai or at Cornell, one of those places. And what he did is a 3D reconstruction of cadaveric prostates. Most cadaveric reconstructions would stop at the urogenital sphincter, and they would dissect the nerves up to this point. What Alsaid and Drupi did is they did 3D reconstructions, computerized graphics, going all the way to the cavernous tissue, the corpus spongiosum and the corpora cavernosa. And what they showed is that the nerves started posterolaterally, then rotated to the surface, to the side of the prostate, and then at the apex of the prostate formed two trunks. The anterior trunk supplied the cavernous tissue, and the posterior trunk supplied the corpus spongiosum. So the neurovascular bundle, or the nervous component of the neurovascular bundle, if you followed it through, went to the corpora spongiosum, not the corpus cavernosum. Now this is just one paper. There may be another abstract that refers to it. Nobody else has shown this, but in fairness to them, these are the only people who traced where these nerves ended. Dr. Walsh's dissection, Dr. Laporte's dissection, all the other dissections stopped here. And of course you found a bunch of nerves there, but you didn't really know where they were going. And I could show you more data about that. This is an article in an optic journal in Korea. And essentially what they did is looked at the fascia covering the prostate. It looked at this, the prostatic capsule, and what they found using optical coherence tomography is that this capsule of the prostate was rich in nervous tissue. This is another MR, and it looks at the prostate, and these are cross-sectional images, and it showed that 30 to 40% of men they had well-defined neurovascular bundle. In 30 to 40, there was a neurovascular bundle, but there were nerves spread all around the prostate, and in about a third, you saw no neurovascular bundle, and the nerves were scattered all the way around. So they raised the thought that there is heterogeneity in the nerve supply around the prostate. In 2016, Fairleigh Reeves, who was a fellow and rotated through through Hopkins and worked with James Boren, who is now at NYU. With Tony Costello, they did cadaveric dissections, and they looked at 6 patients or 8 patients who had radical prostatectomy, and they looked at their hemiprostates, and they did very careful analysis of the nerve supply. And essentially what they found is not a single discrete neurovascular bundle, but a network of nerves that went from the midline all the way to the front of the prostate. So this is 12 o'clock and this is 6 o'clock. So this is figure 3 from their paper. And if you were to look at this, where would you say the bulk of the nerves are? You'd think that they are here, right? So, and if you look at it, they're here. So they start in the midline and they go all the way up to the sides, up to about 9 o'clock, but they also go up to 11 or 12. What is missing in this diagram? What is missing is the seminal vesicles. And why are the seminal vesicles missing? Because when the technician processes the specimen and when the pathologist embeds the specimen, they remove the seminal vesicles and look just at the prostate. So the American College of Pathology, this is what they recommend. The European Association of Pathology and Urology, this is what they recommend. Everywhere in the world, people look at the prostate, but not the seminal vesicles. And when you're looking at the nerve supply of the prostate, you are missing the nerve supply around the seminal vesicle. So I felt that there were nerves here in what might be called the anterior layer of Denavier's fascia. These nerves do make nitric oxide. These are nitric oxide stains, and they have a role in erectogenic function. If you assume that all of this is true, then I think it follows that it is impossible to maintain erectile function reproducibly if the whole prostate is treated, whether it is radiation therapy or surgery. And 2 cerebral urologists, Hashim Ahmed, who is a professor, chairman at University College London, and Mark Emberton, felt that you should not treat the entire prostate. You should use focal therapy if you wanted to maintain erectile function. So they published a seminal paper in Lancet in 2012 and talked about a study using focal HIFU for the treatment of localized prostate cancer. And this is the diagram that they had. If the cancer was in the left lobe, you treated that and you preserved both neurovascular bundles. If the cancer was in the left lobe and you had another cancer on the right lobe, then you treated both of those and preserved the neurovascular bundle on this side. You may damage the neurovascular bundle here because this cancer is close to the neurovascular bundle. And if the cancer was in the midline, you went across the midline and you treated them all. And the pro forma of treatment, their protocol, was that you should have a 5 millimeter kill above the visible tumor on an MRI, and that the lesion of destruction should be 10 millimeters from the prostatic capsule. So if you added these together, then you would have to have a tumor that was 15 millimeters from the edge of the prostate for that to be destroyed by focal HIFU. Now, their results were spectacular, and this shows erections sufficient for penetration. It's not the same number that Mulhall was using. Mulhall was using normal erections. Here, they were just using erections satisfactory for penetration. And essentially what they found is that 84% of men were having intercourse by 1 year, with a 95% confidence interval of 66 to 95%. They did have ED for about a month. By 3 months, erections were back to baseline. And this was staggering. It was a paper in The Lancet, and these results are far different from the 42% that I showed after a total radical prostatectomy in our hands, and the 17% with injections that Mulhall was able to get in Easton's and Scardino's patients. And once again, if you assume that I was telling the truth or divining the truth as best as I could, and so was John Mulhall, and so were Hashim Ahmed and Emberton, then you come to the inescapable conclusion that partial treatment results in much better functional outcomes than total treatment. So I'm going to stop there, and I want you to tell me what the weakness of this argument is. And assume that I haven't misquoted any of this, that all of this is correct. Why don't we just, yes? We have not provided oncologic outcomes. So they have, and that's absolutely what I came from it. And what they saw is that any cancer on biopsy, and this is a protocol by the MRC, so all of them had to have a biopsy at 1 year, was 23%. But clinically significant cancer, and they defined it as greater than 3 millimeter core, or Gleason 3+4 and above, was 8%. So the oncologic control seems pretty darn good. But when you go and when I went and read the paper, their protocol allowed them to biopsy only the lesion that they had treated. This was a proof of principle study. These biopsies were done, saturation biopsies under anesthesia, so they were not allowed to put the patient to sleep just to do a biopsy for a study. So all their IRB allowed them to do was to biopsy the treated area. So all they could say is that where we actually nuked you, we were able to destroy the cancer. They could make no comments about whether this took care of the cancer in the entire prostate. So I felt this was great. I mean, I thought the study was wonderful. We had Hashim Ahmed come down, spend 3 days as a visiting professor. We picked his brains, and he is absolutely brilliant. I've talked to Mark Emberton a number of times, and the data were rock solid. Medicare, the FDA did not approve focal HIFU at the point in 2012 when this study was being done. So we were waiting to get FDA approval. In the meantime, I wanted to see what the cancer control might be. And how would I do that experiment? I don't have HIFU. I am doing a bunch of radical prostatectomies. I want to know how many patients would have missed cancer in people who might have been candidates for a HIFU. And how do I do that in a clinical setting? I'm a doctor seeing patients. How do I do this experiment? So, you could do that in imaging, but imaging is not going to give you the answer. In order for something to be detected on an MRI, it has to be 1 cubic centimeter or 1 billion cells. If you had 800 million cells, you wouldn't pick it up on an MR. So I wanted something more robust than that. Imaging is a self-fulfilling prophecy. What Ahmed and Emberton did is they said, if the cancer is not detected on imaging, it's not worth treating. So we can image and treat, and image-guided therapy is the best way. I turned the question around. Why do they say that? What controls do they have? And while I'm twiddling my thumbs, waiting for the insurance companies and the FDA to approve focal HIFU, what can I do? And so what I did is I wrote down some questions I had. A 15 millimeter margin was obtainable in less than 10%. With HIFU, we are not sampling the rest of the prostate. And if you were a researcher, you know that medicine is going the way of precision medicine, and you have no tissue. You have all these prostate cancer patients, and you have no tissue to do genetic analysis on. So I wondered whether there was a better way in which we can do it. So I had one of the slides is missing. I was going to show you the names of the people who were involved in it. A urology fellow. This is what June would have taken over if she had wanted to do it, and this is what we were talking about. But June's predecessor, and a pathology fellow, and the head of GU pathology together. I asked them to do prostate mapping studies on patients who would have been candidates for an HIFU. So these were patients who had a Gleason 3+4. I wasn't looking at the active surveillance patients. These were patients with intermediate risk cancer who had a defined lesion either on an MRI or on a biopsy. All of these patients ended up having a radical prostatectomy, and I wanted to see these patients whom, if HIFU had been available, I would have been pushing HIFU on. What did I find out in the prostates that I took out? And essentially what I found is that there was cancer in the peripheral zone in 96% of the patients, which would have been beyond the 15 millimeter margin that HIFU was safely allowed to. If we did HIFU on a lesion that was detected on imaging, we would have destroyed 30% of the cancers. So if your protocol only allowed you to biopsy this area, you would have had a false sense of reassurance because you would have destroyed those cancers. The field had changed from focal HIFU while this was going on, and the standard of care that they recommended was hemiablation. So hemiablation all of a sudden allows you to treat patients whom you don't detect on an MRI because you're just destroying half the prostate. And if we did that, we would have removed cancer in 50% of the patients. Kanika Taneja was the pathologist who did this, and she took her about 8 hours to go back and look at each specimen and painstakingly detail where the cancers were. Saurabh Arora was the urology fellow, a husband and wife team. Isaac Palmer Zamora was another fellow who did the clinical correlation, and Nilesh Gupta was the pathologist. So we thought, let's try and see whether we can remove more than 50% of the cancer. This is an orange. Think about it as if this was the prostate gland. An orange has a peel, and an orange has the flesh of the orange. The prostate has a peel, we call that the capsule, and the prostate has the flesh of the orange, which is the glands of the prostate. Cancers of the prostate start in the flesh of the prostate, in the orange, if you will, and will then gradually extend out through the peel before they spread outside the prostate. The nerves that maintain erection are scattered through the capsule of the prostate. So
would it be possible for us to find an area of the peel that did not have cancer? And if we were able to preserve it, would we be able to preserve more nerves, and would that result in better function? And the answer to this is yes, yes, and yes. We can find out if cancer is in the peel by a fairly simple method, which is biopsying the peel. Look at the prostate. Most biopsies are done in 2D. So you just put a needle through the prostate. Can we biopsy this in 3D so that you can sample the peel more accurately? And this is what we do. There is a 3D biopsy machine that was just approved by the FDA about a year ago. We've got that machine about 6 months ago, and we have protocol for doing the 3D biopsy and seeing whether that can allow us to map the cancer better. We found that we can map the cancer better. In very selected patients, we can preserve the peel. All you're doing is preserving the peel or the capsule of the prostate. This is just 4 to 5 millimeters of thickness. But preserving that resulted in an increase in the potency rate from 47% at 1 year to 85 to 95% at 1 year. I mean, this is a huge difference.
So again, this is the informed consent that goes to the patients. They get a link to the YouTube video, they go look at it and ask questions, and then they call us with the questions. So in a total prostatectomy, you'd be removing the entire prostate. In a precision prostatectomy, you'd try to find out which area of the capsule there was no cancer in by the best way you can do it, which is by biopsy, and then you try to preserve that. So a patient who had a precision prostatectomy would look like this. Here's the seminal vesicle. Here's the ejaculatory duct. I start by sneaking in the midline in front of the ejaculatory duct, and we do this on the side where there is no cancer. So this patient is having a right precision prostatectomy. The left seminal vesicle and the prostate are removed, and then you just leave a little scimitar or a cocked hat of tissue. And if you saw that 3D image, it looks a little bit like a cocked hat. This is what we leave behind. And the theory was that you would be leaving all these nerves intact. And here is again one of those mapping studies that we did. And this shows the vasa, it shows the seminal vesicle, and look at the nerves, the nitric oxide producing nerves that exist between the seminal vesicle and the seminal vesicle and the vas. And when our pathologists quantitated them, there were as many nerves that they found there as they found in the traditional neurovascular bundle. Yep.
What percentage of your patients qualify for this surgery?
For the precision prostatectomy. I have the data, the next thing. So the question was, what percentage of the patients qualified for that? And that's a very important question. If you looked at the focal therapy study, they had about 40 patients, maybe 47 patients over 2 centers and 3 years. So they were doing about a case a month. So if you make your indication so restrictive, you'd never be able to have large numbers. So to me, I had to increase this because I was trying to optimize functional outcomes in the largest number of patients. So more importantly, this is all great theory, but would it work? And those of you who are Yankee fans will know that Yogi Berra said, in theory, there is no difference between theory and practice, but in practice there is. So did things work? So this slide you've seen before. This is after focal HIFU. This is Ahmed's and Emberton series. And it showed that 90% of men resumed erections within 3 months. This is what we found after precision prostatectomy. You could tweak these numbers, and I could make this come further down, but in the state of Michigan, I don't collect my own data. We have a consortium called the Michigan Urologic Surgery Improvement Collaborative. So all the data gets sent blindly to the University of Michigan, where this group of Blue Cross and the University of Michigan collects the data and tells you what they found. So the data from 3 months onwards, I don't have the ability to collect. I do have the ability to collect data up to 3 months because the consortium only starts 3 months after surgery. So here's your question. In 2017, I saw 93 patients who qualified for precision prostatectomy out of about 200 patients that I operated on that year. So what were the indications? A Gleason 3+4, a SHIM score of 17 and above, and a desire to maintain erectile function. Those were just the 3 criteria that I had. And of these patients, after I explained everything to them and told them that I was essentially leaving some of the prostate behind, I didn't know what the PSA was going to be, and they were going to be part of this continuous quality initiative. 56 of them chose to have radical prostatectomy, bilateral nerve-sparing radical prostatectomy. 37 chose to have precision prostatectomy. At 1 month, 89% of the patients who had capsular preservation had penetrative intercourse, compared to 16% at 1 month. At 4 months, 32% of men were having erections and sex, and at 12 months, 70% of them were having intercourse. Once again, we used injections, and about a third of them, of these men, like in Mulhall series, were using injections. For the precision prostatectomy, 90% at 1 month, 90% at 4 months, 96% at 12 months. 4% of these men were using injections. So this was natural erections. Now they're all on PDE5 inhibitors. There is a change in erectile function. It's not as good as it was before, but this is a lot better than this, than what we were doing in 2016. If I were to do a randomized controlled trial, and I looked at the difference of erectile function at 1 month of between 89% and 16%, the study would have to be stopped at 8 patients in each arm because the numbers would have reached statistical significance. I was worried about the PSA. I didn't know what the PSA would be. And this is the PSA pattern for patient number 1 to patient number 47. This was the pre-op PSA, and it was around 5.7 for them. At 1 month, the PSA was around 2. At 4 months, it continued to drop, excepting this one patient. And at 8 months and at 12 months, the PSA continued to drop. In 2 weeks, I would have a 2-year follow-up on the first patients, but just the first patients. So the data is preliminary. The median PSA in these patients was 0.1, which was a pleasant surprise. It's not something that I had anticipated. So in summary, erectile function is better preserved after MPP, which is Menon's precision prostatectomy, than total prostatectomy. In focal therapy, only the index lesion is ablated. In precision prostatectomy, all index and most and all satellite lesions are removed. Patients should be followed with low intensity active surveillance in a prospective cohort trial. We will have a randomized controlled trial that we're going to do, and I can talk to you about the details of that. It's a tough trial to do because you have to show the superiority in erectile function and non-inferiority in PSA recurrences and biopsy recurrences. So you've got to fashion that study just so. Our IRB is looking at it. They've come back with criticisms, but I'm not sure, but I hope that we'll be able to start the randomized trial in January, when they will have the 2-year follow-up. So that's what we're going to do. So organ-preserving surgery is now accepted for breast cancer. And Bernie Fisher, when he first talked about it in 1980, said, "Scientific method trumps empiricism, anecdotalism, and inductivism. But don't underestimate market forces, long-standing habits, influence of industry, politics, and profit motives." Dr. Fisher published a randomized trial of 150,000 patients, he published a randomized trial of 10 or 15,000 with a 7-year follow-up, a 15-year follow-up, a 20-year follow-up, and a 25-year follow-up over 100 centers and 2,000 surgeons. In maybe the mid-90s, their audit committee found that 6 patients in one of the centers in Montreal, out of these 2,000 patients, had the dates of their biopsies entered wrong. In other words, their biopsy dates were after they had their surgery. And so Dr. Fisher audited that, and he found that one of the centers was falsifying the data. He eliminated those 8 patients, ran the analysis, and it was published in the New England Journal of Medicine. But he lost his job. He was investigated by a congressional committee. He was forced to step down as the head of the National Breast Protocol. He was prevented from taking part in clinical trials or looking after patients and was summarily dismissed from the University of Pittsburgh. The women who were his most passionate supporters turned against him, and there was a congressional hearing that lasted for 2 years. His career was ruined. He turned around and countersued, and he won at every single level and was reinstated with full honors with an apology from the University of Pittsburgh and the National Cancer Institute. So when you go from a radical mastectomy to a lumpectomy, or in our case, from a radical prostatectomy to a subtotal prostatectomy, you are taking your career in your hands, and you owe it to yourself, your family, and to your patients to be completely thorough and transparent in your studies. But I work at Henry Ford Hospital. That was founded by Henry Ford. And he said, if I had asked people what they wanted, they would have said faster horses. Thank you.
Questions for Dr. Menon?
Yes.
Can I ask you, Dr. Menon, the gestalt or the thought process makes complete sense that you can remove the disease segment of the organ and preserve the areas around the nerves. Clearly, that's what you want to do. Like the breast, because it's location, it's an easier organ to perform a nerve, and spare surgery on the prostate, of course, is different. Can you maybe comment a little bit on how you perform a
So in these patients, in the first 2 years, it was very simple. If you had unilateral disease, so you came in from anywhere you want, and your transrectal ultrasound biopsies showed cancer in just one lobe of the prostate, the likelihood that you will have cancer in the capsule on the other side that you're leaving behind was about 8%. And how do we know that? Because we studied them. They all had radical prostatectomies, and what 8% of those patients, we would have missed the cancer with this particular procedure. If they had bilateral disease, then we would have missed a few cancer cells about 40% of the time, 30 to 40% of the time, and 20% of the time that would be a Gleason 7 that we were missing. So that was something that I was wrestling with. We did intraoperative biopsies in all of them, but it just wasn't accurate enough. That's why we started doing the 3D biopsy. How do we do this? I needed a landmark. You're not doing an adenomectomy here. You are going in and you're just leaving 3 to 5 millimeters of the prostatic capsule. How do we know we left 3 to 5 millimeters? We measured it. We used in a drop-in probe that we use for partial nephrectomies and measured the thickness of every cell that we were leaving behind. And then you could also follow it with sophisticated ultrasound. You couldn't see this on an MR because everything looks jumbled after you do this. So I had to get to that plane, that 3 millimeter plane, and what I did is I followed the ejaculatory duct. Remember, I was trying to preserve the nerves in the anterior layer of Denavius fascia, the nerves between the seminal vesicles and the vasa. So what I would do is start in the midline and just follow the ejaculatory duct. Go into the prostate where the ejaculatory duct went into the verumontanum, then I would come around, and then I would go back and do 4 to 5 millimeters. And that was, and is, still tough. 5 millimeters could be 3 millimeters in someone and 8 millimeters in that same patient further down. So it is a tough operation. It's a bloody operation, so I just use cautery. And I turned the cautery. If one of you came and saw the operation, you'd say, there is no way that any one of your patients are being potent. But then, if I had you sit in my office and I told my secretary to call 8 random patients, you'd find the difference in that. I'm not sure that that's all I'll do. I think it works well for people with unilateral cancer, but for bilateral cancer, I'd like to refine the technique, and this is what we'll do as part of the randomized controlled trial. Essentially, I'll do a total prostatectomy on both sides. So instead of going down between the seminal vesicles and the vasa and flipping them up, I'll just go between the seminal vesicles and the prostate and then remove everything. So that will allow me to save about 1,000 nerves more from 4 o'clock to 8 o'clock. But I don't know whether that will work. This works, and it's fine if all you have is unilateral cancer. But then, as you said, you're restricting the number of candidates for the procedure. If you could do it in patients with bilateral biopsies, then I think you'd be able to do this in just about anyone. I mean, you'd be able to do it in patients with Gleason 4+3. So for 2019, I would hope to do the RCT. And the RCT will have 2 arms. One arm will be radical prostatectomy. And depending on the surgeon preference, we would either use the Menon approach or the Bocciardi approach. And the second arm will be the precision prostatectomy. If the tumor is unilateral, you'll have this procedure. If the tumor is bilateral, you'll have a total prostatectomy. So some of the numbers are not going to be as dramatic as the difference between 90% and 15%. The study is powered to look at a difference of 30% to 70%. And I'll need to do 30 patients in each arm to fulfill the criteria.
Have you had to think about redefining the threshold for PSA that would characterize a biochemical recurrence being that you're now leaving intentionally, let's say, hopefully normal prostate glands intact?
Yeah. So, and I'd be leaving some cancer too, because there's no question that if you leave prostatic tissue, you're going to leave a few glands. So how would you define PSA recurrence? I mean, think that you are Menon, or, and this is 2016, and you're starting to do this operation and defining it, and there's a patient, and he wants to know, what's my PSA recurrence going to be? How would you define it? PSA doubling time. Excellent. So you could look at the PSA doubling time. You can look at the Phoenix criteria, right? Because when you use radiation therapy, you leave the prostate. Oops. Can I go back to... can I look at my slides again? Okay, thank you. This, you had that, go back to that last slide. Yeah, keep going. Go up. Keep going down. I don't. There was a slide that says PSA. No. These are the that one. Slide 33. So these are all the PSAs that we had, Jeff. So this gentleman had a PSA of 15. In 1 month, it came down to 1 or 2, and it stayed low up to 12 months. This one, who was patient number 3, the PSA came down to about 4. And this is when I was figuring out the technique. And then his PSA went up to 6, which was greater than his preoperative PSA. When we measured his prostate, he had 8.5 grams of tissue that was left behind. And that was far more than my targeted of 1 gram of tissue. So I told him that he failed and that he needed to have a radical prostatectomy. And he told me, well, I got a new girlfriend, and she had me go on a roller coaster, and I was on roller coasters all day yesterday, and I got my PSA after that. Do you think the roller coaster had something to do with the PSA? So I said, I don't think so, but let's just see. And he did not want to have a radical prostatectomy. He did not want to have a biopsy. He decided to wait, and his PSA got to be undetectable in 4 months' time. What seems to happen in these patients is that the prostate involutes over follow-up. So I thought, and when I talked to them, I told them that the PSA is going to be about 1 to 2. We don't know what to make of it, much as we don't know what to make of after focal HIFU. The average PSA is about 2.3 to 4 in Hashim Ahmed's series. We could look at the PSA doubling time, or we could look at the Phoenix criteria. If we did look at the PSA doubling time or the Phoenix criteria, we would have 0 failures out of the first 47 patients we did. And the median PSA was 0.1, which means that of the 47, 24 had an undetectable PSA, and 23 had a PSA that was detectable. The average PSA was 0.3. So with the exception of 1 or 2 outliers in whom I just did a bad operation, they seem to have very, very good results. When I go back and try to do the biopsies, I don't see, I'm not able to see this capsule. That is just tissue. It blends into the pelvic musculature. I am able to see this, and I am able to biopsy that. And of the first 47, 2 of them have a Gleason, one had a Gleason 3+3, and one had a Gleason 3+4. The patient who had the Gleason 3+4, I went in and redid this case, removed this tissue. Now he has an undetectable PSA. His potency was not changed. So I removed all of this. I removed this tissue, I removed the ejaculatory duct, and I removed the seminal vesicle, which was a surprisingly easy job, and I won't go into the technique behind it. This could be done without violating the urinary system. We just removed the tissue. It was an outpatient procedure. He didn't need a Foley catheter, didn't need any drainage, and he went home. But there's no question that we will have more recurrences with this. And the oncologic control needs to be defined. Yeah. And I could be completely wrong about everything that I said. Yes?
So, I mean, the first slide was comparing breast cancer and prostate cancer, and for women who are diagnosed with breast cancer, is on average 5 years younger than women diagnosed with prostate cancer. The radical mastectomy, you know, is a grossly disfiguring operation, highly morbid, that has significant, you know, consequences in terms of a woman's physical and emotional, you know, life going forward. So what is your motivation for reinventing the laparoscopic prostatectomy? And we're just talking about at the end of the day, men, you know, an absolute sort of increase in men requiring intracorporeal injections that are in their late 60s and 70s.
So the question is, who the hell cares? You know, men do care. You might too. But that's a value judgment that is a shared decision-making process. So of the people that I talked to, of the 97 patients that we talked to, 60 of them did not care, and they would rather have the whole cancer removed. But I am not prepared to make a judgment that, you know, what drove Bernard Fisher to do a lumpectomy was the morbidity of the Halsted procedure where you took the muscle. But he could simply have done a total mastectomy. That's not what he did. And those were the emotional well-being that is important for a woman having a breast. You could have breast reconstruction, and it's a value judgment that this is important for your psyche. It's been measured, and it is important to the psyche. No matter what you do, you don't have the nipple sensation and you don't have the areola sensation unless you do an areola preserving mastectomy. But even that is considered important for a woman's well-being. For many men, erectile function is important for them. So I showed you our numbers not changing, and I showed you Mulhall's numbers not changing. Like them, we collected those numbers from 2008 onwards. Every person who comes to see me, they fill out a personal priority score as what's important to you. And you start with 10, which is the most important, and 1, which is the least important. So when they come in, by far the most important thing for them is cancer control. And that's, if you average them, it's a 9.8 for all these patients. And the least important thing for them is out-of-pocket costs. Now, it's not important to them because somebody else is paying their bills, so they're covered by insurance. If they had to pay out-of-pocket, yes, then it would be important to them. But for most men, erectile function was not as the most important thing for them was cancer control. The second most important thing for them, and I've done 5,000 patients that I've given this questionnaire, is the safety of the operation. They came to see me because they thought their complications would be lower. I hadn't thought that that would be the thing, but that was the second most important. The third most important thing was continence, and the fourth was potency. Give them the same questionnaire 6 months later. Their PSA is undetectable. They haven't died because they're still filling out the questionnaire. They are continent. What do you think is the most important for them now? It's erectile function. So you're very correct. This is a shared decision-making process, and it should not be offered to someone who clearly is not interested in maintaining erectile function. But if you give patients a choice, and if you tell them, we can do what was done for breast cancer, about a third of the men choose to have that done. 2/3 don't. I suspect that will change over the next 5 years, but I don't know that. Yeah.
Can you talk about the relation, sort of the interplay between surgery like this and active surveillance? So let's say you have a person who comes in, at least in 3+4, some of those patients are being surveilled now. Is there a window that you perceive as closing, or is having all the repeated biopsies going to somehow impair your ability to map out the capsule? Or could this just flat out replace active surveillance? If you're maintaining confidence, you're maintaining, or rather potence, and so you're basically saying, hey, let's take a shot at curing cancer, assuming you're a good surgical candidate with very little morbidity. So I'm wondering if this pans out, should we be doing active surveillance?
Very good question. I asked myself the same question, and that's the slide I showed. Why don't we use active surveillance for a woman with a 2 mm cancer that's detected on mammography? It's just not done. There is no pivot study where you take a 2 mm lesion and follow it and randomize it to a lumpectomy versus observation. It isn't done. But we do it for prostate, and that is intellectual inconsistencies that we see. These patients are not candidates for active surveillance. They were not. So if you had a focal Gleason 3+3, they went on the active surveillance protocol. They were not offered this. These were people who chose to have surgery. So they had pre-selected. They did not want to have radiation therapy. They did not want to have active surveillance. They wanted to have the cancer removed. And they were given a choice between a precision prostatectomy or a complete prostatectomy. So the question that you ask, I think, is a fascinating question. Why do we not do PSAs? Why do we not take the prostate out? Because we're worried about the side effects. And the side effects are incontinence, which pretty much a good robotic surgeon, you don't get incontinence. But ED is there. Our best surgeons have an 80% ED rate. So very clearly, the loss of function with this operation is erectile function. So if you were able to ameliorate erectile function, would you be better off having the prostate removed and not worrying about the cancer than having biopsies every year? Active surveillance at this point, and they're changing the protocol, the data for Gleason 7s is smaller than it is for Gleason 6s, but the recommendation is that you have a biopsy every year. And that's tough to do. Would some patients not be better served by just having the prostate removed? I don't know. I think if this data can be reproducible and if other people get the same thing, that is a question worth asking.
So we're going to have to wrap it up soon.
Yep.
I just want to review when Dr. Menon and I were hatching the idea of talking about precision prostatectomy. We talked about the history of what we thought we knew, or what those in the know thought they knew about the anatomy of the nervi urgentes. I thought it went back to about 1960 when a doctor in San Francisco named Alex Finkel imagined the nervi urgenti, which turned out to be the ones that were actually demonstrated by a Balchan doctor. And Dr. Menon came up with the German anatomic drawing that clearly evidenced that these nerves were not just imagined, but were actually demonstrated back in the 19th century. So, you know, to go back to Mark Twain, you know, in terms of knowledge, it's not what you don't know that gets you into trouble. It's what you think you know, it just ain't so. And so when I had gone into radical prostatectomy and thinking about the mechanism of action of the side effects and the ergogenic dysfunction that happens after radical prostatectomy, I had that picture of what I thought was the facts of the anatomy, as demonstrated particularly by my hero, Dr. Patrick Walsh. And Dr. Menon, not even his own work, but has demonstrated that other work has demonstrated that those nerves are not where we thought they were. And so basically, I thought this was the ultimate demonstration of thinking out of the box and rejecting what is thought to be common knowledge, axioms that we learn, and we get into rigid thinking. So I think the lesson here, although this is one of the most interesting lectures I've ever heard, and it's certainly very much applicable to this large part of our practice, is the larger lesson in terms of opening your mind and looking at what's in front of you and asking if you see something that's not right, try to seek the truth. And obviously research is a big part, which is why we're in an academic medical center. But this was a tremendous learning experience for me, Dr. Menon, so thank you so much for coming.